Hello geeks, this is Brian Kui from medcodinggeek.com with another video for you. In today's video, we are going to go over the CDEI course syllabus. Last video, I did an overview of the hashtag FREEAAPC. And in going through the websites provided by AAPC that explains the free course training, the CDEI training was offered. So in this video, I'm going to go over that course syllabus, plus also give you my feedback on the course syllabus as well. All right, so before we begin, I am going to go over to our YouTube channel. If you guys are enjoying these videos, please consider subscribing. The video that I just recently did for the FREEAAPC is doing really well. We got about 437 views as of this video recording. So it's been very popular compared to the other videos that you see here, because everybody loves free. Who doesn't love free? But you know, this training here is really awesome. It's about $1,800 worth. I'll give you my feedback. But again, before I even begin, please subscribe to this channel. If you're new to this channel, please also check out our videos. I do videos on health information management, clinical documentation integrity. I also do mentoring sessions with students. I bring students out and record them because I think we need to have more student interaction. I also talk about other things as well. I do a vlog once in a while. But yes, please feel free to check out this channel. Please subscribe to this channel, and it helps supports us. All right, so let's get into what got this video started, right? So I'm going to go back to the FREEAAPC. So the last video I did that for you guys. And one of the things that we did in the last video was go into option A. So option A is the free CDEI course, which is valued at $1,804, which is a great amount. And, you know, people are probably wondering, well, what is involved in this $1,800 training? And when you go to the actual CDEI online clinical documentation improvement training course, you'll see here what it entails. But before I even get started with the course syllabus, okay, here's how they marketed this program, or the reason to enroll to this free training, which, by the way, it ends September. Well, the offer ends September 30th. So you have about, let's see, what's today? Today is checking my dates, the 26th. So as of today, end of today, you have about 3 days tomorrow. 3 days left after today, on the 27th. So you have a few days left. So please, I highly suggest you take advantage of it. $1,800. Hello. Here's the 5 reasons to enroll according to AAPC. A successful completion of this course indicates the student has prepared to take the CDEI exam and begin. That is the key phrase. Begin. And I'll explain why, right? It's not like you're a master after you take this exam. You are going to begin, right? And I'll talk about why. Number 2, self-paced course, convenient for work flexibles. Okay, that's fine because it's online. Certified coaches available to answer questions. All right. Low cost compared to other training programs. I might have to do a comparison. So $1,800 for what, 20 CEUs upon completion. I'll do a quick comparison. I'm going to check other websites in a second. A great way to supplement for any coder interested in the CDI program. Yes, I'll talk about that too. Here, low cost compared to other training programs. Now, your best bet in comparison with the CDEI is the AHIMA CDIP, which is the Clinical Documentation Practitioner, which I currently have. There's also the Association of Clinical Document Specialists that offers the CCDS. By the way, I did an introduction to CDEI, so I highly suggest you check that out for a little bit more background on the, I guess, the landscape of what CDEI looks like. And I explained a little bit more into that. But anyways, here's what I found. Low cost, so AAPC proclaims it's low cost to other training programs. All right, so I'm going to compare this to the Association of Clinical Documentation Specialists. A bit of history. To tell you the truth, they were the first ones who took advantage of the CDI market and responded well with the people wanting to know more and to get involved in CDI. So this is how the ACDIS was born. Here is the CCDS certification, which is somewhat of an equivalent to the Inpatient CDEI by AAPC, but AAPC is proclaiming it is low cost. Here's your cost of the CDI Clinical Documentation Integrity Boot Camp, which, by the way, the training people over there is top notch. Nurses, physicians, and HIM professionals. Okay, so you want to do your research. Okay, do your due diligence, as I've been told by colleagues. So my initial thought, $1,800 is a lot, right? So could you save yourself, just going for the CCDS? Possibly. It's up to you, right? So I'm really let me go back here. So in one of these videos here, the video that I did for AAPC, even though I do a video for AAPC, I'm just going to say this, is I'm not bashing AAPC. I am not scaring AAPC certified credentialed coders. What I'm doing in this video, and as I mentioned in that video, I have no association ties. There's nothing that I gain from doing these videos for AAPC compared to other YouTubers that are out there that are associated with AAPC. And they offer training according to AAPC. I don't, okay? I want to give you a holistic view, okay, of the coding landscape for all associations, not just AAPC. All right, so I received that comment, I think, on this video, and I'm actually responding with that. And because of that, I think I got a dislike. But I could care less, right? So here we go again. $1,800 low cost. Nope, there is $1,099. But the one thing that I can say is that this is free, all right? Compared to ACDIS that doesn't offer anything for free, just to tell you the truth. So the fact that AAPC is offering this training for free is a plus in my book. Okay, overpriced, yes, but because it's free for a few days, all right, take advantage of it. Okay, all right. So before I even get started with the CDEI course syllabus, let me give you a little background from me on this exam. All right. So I was actually part of this committee to develop this syllabus. I didn't develop the syllabus in total, but I helped contribute to the syllabus. I also helped contribute some of the exam questions. I was on the committee for, I think, 1 to 2 months. And I provided some questions, and to tell you the truth, it is very tough to write questions. I can explain to you a lot of the concepts from this syllabus, but to write questions, it is very difficult. So the committee is a team of highly experienced CDEI professionals that range from nurses, range from coders, myself. There was a physician that came aboard before I had decided to step away from the committee, and of course the AAPC folks that moderated or oversaw this committee, they kept the committee on track. If you're talking about project management, boy, they really kept it on track. Now, the reason why I had left is because it was a lot. I think when we go over the syllabus, I can tell you, there are a lot of questions. It's just tough to write questions. And what happened is that I was assigned to do questions. And I think just writing, I don't know how many, like 4 questions alone took a lot of my time and per week. And it really took a lot on top of, in 2020 was the pandemic. I was doing the podcast. I was doing my actual work full time plus overtime. And I think the writing of the questions kind of put me over. So I do talk about in the videos, in the Medical Coding Geek videos, about burnout. And I think I had reached that point, a couple of times. And I've just learned over the years just let it go. One of the reason why I was approached, to tell you the truth, was my name came up because I did the national conference in 2020. Craig reached out to me and asked me, "Hey, would you be interested in being part of the committee?" I said yes, and one of the conditions is that if you stay on and complete the committee, you will get the CDEI, and that intrigued me. Getting the inpatient and getting this credential really wasn't something that I needed, but I think it was a way for me to get involved with AAPC, and I've been involved with AAPC local chapters for quite some time. Speaking at local chapters about clinical documentation integrity. And I thought getting the CDEI by helping out AAPC with this examination would do that. But at the end of the day, it was too much on my plate. But I did, for me, I contributed a lot with the time that I provided. But yeah, that's the story. Let us go into the syllabus. Okay, so this syllabus is about 4 pages. I'm just going to go over it. All right, so hopefully this is not going to be a super long video, but here it is. The CDEI Inpatient Course Training Course Syllabus. Prerequisites. Minimum 2 years inpatient coding experience and coding certification strongly recommended. Okay, strongly recommended. It is strongly recommended, not required. Compared to the CCDS, the Certified Clinical Documentation Specialist, that is brought to you by the ACDIS, Association of Clinical Documentation Integrity Specialists. They require 2 years in patient experience. Now, the CDIP by AHIMA used to require 2 years of experience, but since then has changed the requirement to a recommendation. Okay, so this for AAPC, I guess they're following that course and only allowing it for recommendation. Okay, so the question is, can somebody new do this? I'll tell you the truth. The questions that I have seen is not for people who are new, unless you have some form of, I don't want to say experience, but exposure. Maybe that's a better word in all of this. Is inpatient exposure. Are you exposed to inpatient? If you have not, I highly suggest you start off with understanding the inpatient coding. Okay, now they don't require it, it's just recommended. So you could just take the course even if you don't have the 2 years of experience. But I suggest before you even get started, you might want to learn the inpatient. So get with the inpatient coder, get with the CDEI first, and just pick their brains a bit. Bring the syllabus to them and have them share their thoughts on what it is. But basically, I'm just going to share my thoughts because I've done CDI for the past 12 years, right? So I'm going to shed my light and share my thoughts on what is on this exam. So the clock hours, 20 hours for the syllabus. That's a lot. Course length, all right. To be completed on, I guess the course has to be completed within 3 months. Oh, wow. At your own pace at 3 months. So you have about 3 months. So that's about what, $600 per month? Just breaking down the math. All right. Enrollment dates begins at the date of purchase. All right. So it's free regardless. But for those that have to pay after that free AAPC, you're talking about $600 per month. All right. Monthly course extensions will, of course, be purchased. Class hours times per week. All right. It's online. I'm not going to go over this. Certificate of completion. Yeah. If you pay $1,800, you better get some type of proof that you finished it. Okay. CEUs, 20 CEUs. Okay. And I'm going to assume this is CDI specific. Okay. Which I think after this certification, we will be in need of CDI speakers to talk about some of the course syllabus items in here. All right. So I'm not going to talk about the course description, but I'm going to go over some of the course objectives. All right. Define the benefits of a CDI program. We talked about that in the initial phases of the committee of why a CDI program is important. Why should it be implemented, which is the second part there. They need to change this phrasing from improvement to integrity. AAPC, if you're listening, you need to change this to integrity because this is the new standard in the industry. Unless you want to stay at improvement, that's fine with me. Describe the implementation of a CDI program for inpatient facilities. So this is an inpatient test, not outpatient. Just keep that in mind. Explain HIPAA privacy rule, including details on protected health information, which is something required. I mean, I don't... when we were brought forth that we needed to add these questions, I'm like, okay, it's just out of formality. But yes, you do need to know HIPAA privacy, PHI, minimum necessary, which I think is very standard for all exams, I believe. Identify medical record documentation standards and retention standards. It's just HIM stuff, health information management. Define the proper use of queries and effective provider communication. I was part of this process here in trying to write questions, and boy, it's just tough to write questions. I can explain to you what to expect from this topic, but I cannot write a question for my life. It's just very time consuming. Describe quality measures and how they apply to clinical documentation. Very good. Summarize the inpatient prospective payment system. Inpatient payment systems, inpatient prospective payment system. Apply ICD-10, CM, and PCS guidelines to clinical documentation, and identify deficiencies and resolutions. Yes, I think I think these questions right here kind of broke me right here. Identify deficiencies and resolutions, the escalation process of CDI. I think that was, if I remember very vaguely, it was last year. That kind of, okay, I'm done. Just to tell you the truth, I'm done with doing this because it's just, on top of that, I was really behind on the clinical questions and it was just a lot. But yes, I can explain this to you, but I cannot make a question for you to do that with. Just keep in mind the question writing process is you have to write a question, come up with 4 choices, provide the right answer, and then provide a rationale. That's a lot of work just for one question, and I was assigned four to five per week, and then sometimes I just couldn't do it. It was all done at night and after work, and I'm like so exhausted, and doing a podcast and all of that. So you could see and understand why it is a tough gig. But for those that stayed, a big kudos. I was happy to contribute to that. Course content: the purpose of an inpatient clinical documentation improvement program. Understand the importance of medical documentation. All right. I think the phrasing should be the importance of physician documentation, right? Why is it important? Physician documentation. If you're trying to look at it at that angle, why is physician documentation important? And you really want to go down the line as to why having accurate physician documentation can lead to accurate code assignment, and that accurate code assignment can lead to appropriate, accurate reimbursement, which then would prevent denials. That's how I see that. And I can talk about this for another another hour. All right. Master the documentation process. I don't know how you would master the documentation process, but I don't understand if there's a process that CDEI does for documentation, but it's all by the physician and making sure it is complete, making sure that the physician indicates the diagnosis, indicates the signs and symptoms associated with it, and apply the testing. Like, these are my findings that came for the diagnosis, and then the treatment. That to me is the documentation process. Implementing a CDEI program, that is to me CDIP level stuff. I'm not too sure what the questions that were being asked in that, but I know it has to deal with metrics, finding the right team. What are some of the requirements of the CDI specialists? Having a nursing degree, having an HIM degree, having inpatient coding experience, etc. Okay. That's just a loaded this is just a loaded topic, if you ask me. Documentation requirements: understand the medical record, identify ownership, who access. This is more HIM stuff. Summarize HIPAA, identify and summarize the regulatory guidelines for the medical record. That's more HIM stuff. If you have an RHIT friend or RHIA friend, this is something that you want to kind of go for. List the components of the medical record. All right. The reason why that's important, because you want to know how to navigate the medical record as a CDI. You are not necessarily, compared to a coder, just going to look for documentation. You're going beyond what is documented and going into areas that you would need to find clinical evidence, such as laboratory radiology, nursing notes, ancillary notes. All right. Provider communication and compliance. Oh boy. This was a tough one because, let's see, identify regulations such as the False Claims Act. Yes. Exclusion statute, civil monetary penalties, and the law. Yes. Right. I agree that this should be talked about, because let me tell you, some of the queries that I see are leading, okay, and results in upcoding and can fall into issues with all of these regulations. Describe the OIG. OIG stands for Office of Inspector General. Okay. Describe the OIG and identify the publications of the OIG. The best place I seriously can think of seeing this OIG being talked about a lot, fraud, waste, and abuse, is by going on LinkedIn. Okay, there are people who I follow that you can actually do a search on OIG. You could find a lot of people there. Sonal Patel, by the way, I think from the Medical Coding Picture, Paint the Medical Coding Picture podcast. Paint the Medical Picture podcast. She does a lot of podcast episodes on fraud, waste, and abuse. So I highly suggest you take a listen to those podcasts and reach out to her. She's very nice. And she could help you out with that. So I'm giving you guys some resources along the way, outside of what AAPC is offering, because you got to go beyond what the resources give you. Summarize the recovery audit contracts. You could find that on the CMS website. Recovery audit contracts is basically the people who do the denials, like me. So I've moved from CDEI to doing not RAC audits, but working for payers who do these audit contracts. Okay. And you can see the other side of how documentation is very important, supporting your conditions with appropriate clinical indicators, supporting clinical indicators. So that way it prevents that denial. List the type of physician queries, right? I mean, how can you write a query? How can you send a query? It's either written, typed, verbal, or I think that's about that's about it. What are the modes that you could send physician queries? Describe how to write a compliant query. And I know you probably might have to write a query on this exam. I believe so. I know that was discussed in the committee. So you have to write out a query. So be prepared on how to do that. If you need help on how to write a query, I mean, I've been doing videos on queries on the vlogs, which I'm about to release a couple because I've seen some badly written queries. But yes, if you have any questions on any of this stuff, please reach out to me. If there's a video that I can do on this process to help you out, let me know and I will do it for free. Explain the mindset of a physician for effective communication. I don't know. See, I think this here, how could, in my opinion, how can you write a question for that? And whoever wrote the question, whoever took over that responsibility, took on that responsibility, kudos for writing a question, because it's, how do you ask that question? But I can tell you how to do it, how to provide effective communication, but how can you write that question? But be prepared for that. But I know here, you have to write it. So be prepared to write one out and somebody has to evaluate that. Quality measures demonstrate the hospital value-based purchasing program. Describe patient safety and quality indicators, right? Because if you have good documentation, the bottom line is you're going to provide patient safety. You're going to provide effective communication between physicians. And so nothing's going to happen to this patient. The patient's going to be safe. Okay. Explain the hospital readmission reduction program. I talk about this in some of the podcasts that I do, but there are initiatives by CMS that tries to reduce hospital readmissions on certain conditions. One of them that I remember back in the day is CHF. There's a 30-day readmission program that tries to prevent patients with CHF to be readmitted again. I believe it's the podcast that I did with Janice Amon. We talked about that very briefly because you could see that this can be very tough. And what happens is that if a patient is readmitted after a certain amount of days, they actually don't reimburse you that full amount. So that's what that idea is. Again, you can get this information on the CMS website. Just look that up. I saw this before I started. Explain Vizient. Now, I didn't add this to the syllabus. I didn't recommend this. I have no idea what this is. What is Vizient? I don't know why they would promote a member-driven. Can I go to this website? Member-driven something. I have no idea. Just to let you know. I don't know if this is what they're talking about. I don't know if, to tell you the truth, I don't know how this is applicable to CDI. All right. So whoever added this in, you're probably going to be trained on it. But if you ask me, in the real world, there's no relevance. Okay. There is no relevance of this Vizient in the, I don't know. I have no clue. Next thing, CMS, inpatient payment system, inpatient prospective payment system. I just did a local chapter, Tampa. Shout out to those at the Tampa AAPC local chapter for inviting me. I did a presentation on diagnosis-related groups. So for those that are watching this and you're an officer and you would like to receive information on diagnosis-related groups, because it's right here. I'd be willing to speak at your chapter to talk about that. You could talk to the officers at AAPC. Even the Greater Orlando chapter, I did that presentation twice. Just to show how, just to give you an overview of DRGs, and I definitely, that can help out with that. I knew I wanted to add this to this exam because that's the major component of CDEI is understanding inpatient CDEI is understanding DRGs. So list the common inpatient payment system reimbursement methodologies. I mean, there's only inpatient prospective payment system, right? So that's the only that's the only one that I know of. Define an inpatient stay. Okay. I guess really what you want to define it as opposed to somebody who's just in the ER, as opposed to inpatient stay versus an observation stay. Observation stay is about what, 24 or 48 hour hospital stay. But hospital inpatient stay is something that is beyond observation status. Okay. Explain discharge disposition. That's important because you need to have the correct discharge disposition, meaning how did they leave? Did they go home? Did they go to a SNF? Did they go to another facility? Did they go to hospice, home hospice? Did they expire? Did they go to jail? Each of those discharge dispositions affects how or what type of billing form do you use. All right, so this is very important. This is very inpatient coding like. Next thing is describe the DRGs and how they affect the reimbursement. I gave a 1.5 hour presentation. Okay, so if you want to get in on this, I mean, I'm not going to do this on the YouTube channel. I'm just going to tell you to go talk to your local officials and have them invite me, and I will do it for their chapter. Okay, so if you want me to do that 1.5 hour presentation, I also do a 1 hour to 2 hour presentation on the overview of CDEI, which is called the CDEI mindset. I highly suggest you ask your officers, hey, I'm about to finish this program. I think this would be very beneficial. I need this. So I'm willing to help you guys out. Define the rules affecting inpatient admission, such as 72-hour rule and the 2 midnight rule. Yes, because that also would go hand in hand with defining the inpatient stay. Identifying hospital-acquired conditions. You could find that on the CMS website. Explain the hospital inpatient quality reporting program. Define major diagnostic categories. That's part of the DRG process. Medicare severity diagnosis related groups and all patient refined. I gave them these names. So yes, you can see how they're written out. And yes, this is part of the DRGs. This is part of the presentation that I do, which is called digging into the DRGs. All right. So if you guys are interested in that, reach out to your local AAPC chapters for that, or officers. List the steps to determine the DRG. Yes. So I can briefly tell you, you got to assign the principal diagnosis, assign your secondary diagnoses, assign your applicable procedures, and it really goes into an encoder and it spits it out. But what I do in the presentation is show you the manual way. Okay, and it all has to do with identifying your complications and comorbidities, your SOIs, ROMs, all of that. Okay, introduction to ICD-10. All right, so this is nothing. This is very basic ICD-10. I know who did the questions. Great guy, very coding savvy. All right, so how do you look up an ICD? This is very basic stuff. I'm not going to go over that. Let's get into the clinical conditions, chapter 1 through 11. Okay, define the condition, signs, symptoms, testing, treatments, coding concepts, coding guidelines for the following conditions. Now, I remember early on in the committee process, they asked the group, what conditions do you see as a CDEI? And I just listed a bunch of them that I knew of, and they're basically listed here. All right. There were other ones, and because of that, I knew you had to have whoever Craig says you need to have more questions. We need to have more questions because this is I think a 5-hour exam. So we kept on providing conditions that may be something on the denial side, perhaps, that you would need to look at. You have to look at it in both ways, from the CDI side and also the denial side, because you're also trying to do clinical validation queries to make sure that condition is present. Okay, so there are also conditions that if you query them may prevent a denial, okay, on its clinical validity. So you're not just documenting, you're not querying just for the sake of, having a physician document a diagnosis. You're also placing queries to make sure that the condition is fully supported. Okay, so that's one thing you could look at. All right, first one, I just didn't feel this one, congenital versus acquired conditions. Within the 12 years, I've only placed a few queries on that. Congenital versus acquired conditions. Sometimes you can get away with how the coding conventions, how it indexes itself out, just to get your, to get through this. HIV/AIDS, yes, I can see where you can query that. If the doctor is writing HIV disease or HIV positive, you're trying to prove if it's AIDS or not. Sepsis, yeah, that's a lot. I could talk about sepsis. I could develop I've done a presentation before. I think it's online on sepsis very early on back in 2015. If I find it, I will put it into the comments. Neoplasms, yes, there's a lot of guidelines in regards to how neoplasms are coded. I think the newest ones is where, for example, if the patient is presented for the symptom of neoplasm, such as neoplasm-related pain, that neoplasm-related pain should be the principal diagnosis versus the actual neoplasm. Adjuvant therapy, I did not suggest that, but I have no clue what's involved with those questions. Active versus history of neoplasm, that's associated with that. Identifying metastatic areas, if it's not documented, if it's in the pathology and it's not documented, you want to get that documented by the physician to reflect on the pathology report. Acute blood loss anemia, there's different types of anemia. I think the idea is identifying the type. Okay. Diabetes, diabetic complications, DKA is a good one. Diabetes uncontrolled. What's the other one? Diabetes uncontrolled. Diabetes uncontrolled is something that needs to be clarified. Because if you go through an encoder, diabetes uncontrolled, it's going to ask you hyperglycemia or hypoglycemia, or it indexes out that way. Malnutrition, yes, a big discussion in the CDI world. Very tough to implement in a CDI program or just in a hospital in general, because there's a lot of silos associated with that. Morbid obesity, BMI, okay, which goes hand in hand with malnutrition. Drug dependence, okay. Major depression, okay. Specifying type, probably severity. Epilepsy versus seizure disorder versus seizures. Seizure disorders goes to epilepsy. There's different types of epilepsy codes, so you might want to get that clarified further. Neuropathy, Parkinson's disease, common conditions. I've never queried, to tell you the truth, about conditions of the ear. I just don't know. Aortic aneurysms, okay. Aortic stenosis, sclerosis, okay. CAD, with or without unstable angina, I guess that's what I'm thinking about. Dissection, aortic aneurysm, dissected or non-dissected. Location, just don't want to get more specifics. Cardiomyopathy, I know there's a lot of types, or just validating if it's a cardiomyopathy. And one thing that when you look at here is if the patient has cardiomyopathy, is their CHF. Okay. Let's see, cardiac conduction conditions, atrial fibrillation, sick sinus syndrome, atrioventricular blocks, complete heart blocks. These are things that you might not want to have clarified, but this would require you to have an understanding of the EKG, electrocardiogram. CVA versus TIA. Oh boy, yeah, there's a lot of guidelines in regards to that, clinical guidelines to differentiate between the both. Okay. Deep vein thrombosis, yes. Every time I see a deep vein thrombosis, I always ask the question, well, what do you need to look for next? Probably a pulmonary embolism, okay, or a CVA or a heart attack. It can lead to other conditions, okay. Heart failure, I already mentioned. There's a long history in regards to that. But I think most important is identifying if it's an acute or chronic. We're not so much into worrying about the type because for the past how many years we've kind of drilled the physicians to identify the type. It's already embedded in electronic health record systems to select. But I think it's more now if there are presenting signs and symptoms that would classify it as an acute condition versus a chronic or acute on chronic. Hemiplegia is very important because you want to identify if it's hemiplegia versus monoplegia. The difference is when you think of hemiplegia, it's the whole entire one side, unilateral side, versus monoplegia, may it be just the arm or the leg, and that's it. So sometimes you see hemiplegia, but then when you look at the examination, maybe just the hand is weak and the leg is doing fine. That's not hemiplegia. You got to look at your definitions. Hypertension, very important. Hypertension urgency, hypertensive emergency, hypertensive crisis. What's the difference? They just, it can be used very freely. We want to make sure that you're assigning the correct code. Hypoxia, I don't know why you would ask that, but yes, there are deep-seated queries that can result in that. That can flag you to look for other conditions that would want you to associate what is the cause of the hypoxia. Maybe pneumonia, maybe COVID-19, it might be respiratory failure, it might be ARDS, right? But there's a different landscape of clinical indicators that you need to look for in order to identify the source of the hypoxia. And most importantly, what is the treatment of that? Myocardial infarction, I've mentioned in presentations, there are 5 types of acute myocardial infarctions. You might want to be very keen on that, especially with type 2 and demand ischemia. They tend to be interchangeably used, but when you look at clinical criteria, it's not necessarily a myocardial infarction. It might be just demand ischemia, and there's a difference. PVD, yes, right? So diabetic PVD could lead to other issues. You want to look at that. Venous stasis ulcers, I didn't add that, but it could lead to other issues for sure. COPD, identifying if it's bronchitis, asthma, exacerbation, could lead to other issues such as respiratory failure. Pneumonia, there's a lot of types out there. Just clinically validating if the patient does have a pneumonia. Crohn's disease. When I think of Crohn's disease, I'm thinking of the colostomy. And when a patient has a colostomy, there may be issues as a result of that. Okay. Cirrhosis, yes, there's a lot of issues with cirrhosis. Where does it come from? Liver cirrhosis. Is it from hep C, hepatitis, alcohol? Is it associated with ascites? Is there hepatic encephalopathy, which they did not add in here? Why didn't they add in encephalopathy? Oh boy. They should add in, by the way, guys, add in encephalopathy. I don't know why this is not discussed here. Encephalopathy should be on that list and be tested. Oh no. Oh geez. Anyways, define conditions, sign and symptoms, testing, treatment for the following for chapters 12 to 22. Pressure ulcers, yes. Define the type and stage, location. Is it present on admission? That is key. Rheumatoid arthritis, I don't know. I didn't write those questions. Pathological osteoporosis fractures, yes. These are very tough because you want to identify if the fracture is traumatic versus non-traumatic. If it's non-traumatic, what is the underlying cause? It may be due to osteoporosis. It may be due to cancer. It may be due to other issues, okay? So you want to look at the underlying cause of the fracture. CKD, identifying the different stages. I think what's most important is when does it get to ESRD? And I can suggest a website. It's kdigo.org. You might want to look at that. One thing that they did not list is acute kidney injury. All right, which I don't see here. I don't know why. What's going on at AAPC? Whoever wrote this syllabus, You need to include acute kidney injury in all of this. So this is something that needs to be discussed as well. Common conditions in pregnancy. Okay. Common conditions in the perinatal period, right? So these are pregnancy OBGYN issues that you should be looked for to potentially querying for. Now, the thing is that most CDI programs in the nation don't really review OB cases, okay? Because there's not that many, and they're in and out very fast. The length of stay for pregnancies is about 2 days. So by the time a CDI would get to it, the patient's already gone. All right. So there are common conditions, but to get to a case in time before it's discharged, because it has to be performed concurrently, can be very difficult. Burns, yes, very important. Site location, degree, all right. Fractures, yes, different types. I think what's most important is the type. Is it traumatic versus non-traumatic? If it's traumatic, what kind of traumatic is it? Where is it located? I think what's also most important is what is the result of the fracture. One thing that is not mentioned in here is multiple significant trauma. That I think is also part of the DRG testing, but that's something that you would want to understand in injuries just in itself, is how to get to multiple significant trauma as a DRG. Head injuries, okay. There's no mention of intracranial hemorrhages, which I have seen and queried a lot, which I think would be very important to discuss, right? That's not listed here. Hopefully that is part of the updated curriculum if you guys are listening. Amputation, artificial. Oh yes, amputations is important because the coding aspect is so hard. Why did the patient have an amputation? I think is the key, because I used to work for a facility and that's all they did. It was a vascular institute, and that's all I saw were amputations. Artificial openings, colostomies, ostomies. This goes hand in hand with Crohn's disease. And having an artificial opening and the complications associated with it. Infection, is it a malfunction? You really get into the nitty gritty to finding the underlying issue. If it's not documented, then we need to get it documented. Transplant status, I mean, it's very good. But I think, yes, it may be a discrepancy in documentation, but I don't see this ever having to query for it. But being aware of it, probably. COVID-19, yes, they just added that on there. Vaping related disorders, I have not seen that. Next thing is the ICD-10-PCS guidelines. Identify the structure of the ICD-10-PCS book. Identify how to use the code book to determine the selection based on documentation, and describe the ICD-10-PCS guideline. Now let me stop here for a second. And let me get over here. I got these books, by the way. I didn't get them, but I was sent them. Not by AAPC, but I just got them in the mail. One of the books that I see here is this book. Here it is. The Expert ICD-10-CM 2022 diagnosis book. Now, there was a question on Facebook that I saw about that they got the training, the person got the training, and then tried to decide which ICD-10-PCS book should I get? Should I get one for the physician or the facility? I think you should get it for the facility. So I'm referring to this book here. I don't know if you guys could see it. Okay. ICD-10-PCS Expert. It says for inpatient procedure codes for facilities. I think that's most important. And the one for the diagnosis, ICD-10-CM Expert, I highly suggest you get one for the facility, because for the physicians, it doesn't really indicate the DRGs. It doesn't show which conditions are CCs or MCCs, but regardless, you could find that on the CMS website. Understanding the PCS, if you haven't worked with PCS, I highly suggest an outside course to help you with that. I don't think 20 hours is enough to get you by, because if you're going to do inpatient coding, you definitely got to know inpatient PCS coding. And one of the tools that I highly suggest, I mean, I may do a video. Hey, I may do, if you want me to do a PCS overview for your AAPC chapter. I'm just plugging myself away shamelessly. Let your officers know I may do that. But you could always find trainings online. One of them being the Haugen Consulting Group, which helps supports this channel and all of the content that I've done, especially with the podcast. So please make sure to check that out. I will link their information below. But one of the tools that they've been giving me for the past couple of years is this one, the PCS root operation ICD-10 PCS flip bits. And I've done a video with this because one of the fellow YouTubers had issues with ICD-10 PCS. I think she was getting her CCS. And I go over this tool. And I think what's most important, what I can say is, if you're trying to work with the ICD-10 PCS table, the one thing that you can get is the first 3 digits of the PCS. But once you get to the root operation, everything else falls into place. So I can explain that. But within 20 hours, boy, I don't think you can get, unless that's why they ask you to have experience. But I mean, if you could get outside training and understanding PCS, that is definitely a plus. Inpatient coding and documentation review, yes. Determine the principal admitting diagnosis, the digital diagnosis, code sequencing. This is all coding, inpatient coding. Apply present on admission indicators. We could talk about that. All right. Review documentation, dissection and query writing example. Yeah. How do you write a query? I would be more than willing to review anybody's queries if you write them. And I'll give you my 2 cents. I will apply them to the 2019 query writing guidelines that was written by joint written by AAPC. I'm not AAPC, AHIMA and the ACDIS. So if you guys have that, just message me here or just find me on LinkedIn, or you could email me at medcodinggeek@gmail.com. And of course, you have your final exam. So here's the method of evaluation, blah, blah, blah. Your books, computer requirements, enrollment fees. So that covers it, right? So this is a very extensive syllabus. I feel, to tell you the truth, that I didn't even show you this. I didn't switch you the screen, but yes, this is the rest of the syllabus right there. Okay. Let's see what else. And that's about it. But what I can tell you is, this training, it's good, but I think there needs to be more. But if you keep on adding more to the syllabus, it's definitely going to go higher than 20 hours, and that $1,800 is just going to go up. I highly suggest, when you're preparing for this exam, look for other resources such as such as ACDIS, right? Check them out. That's acdis.org. They have some great materials. Actually, to tell you the truth, when I studied for my CDIP exam, I didn't have any books for the exam because they didn't develop it yet. So I actually went to ACDIS and bought their study guide. So maybe you can get their study guide. I believe it's $99. It has some questions, has some concepts. AHIMA has a study guide for their CDIP exam. You'll get an idea of what they'll ask, and it may correlate with the CDEI exam. So I think you should do that. But yes, if you have any questions after looking at this syllabus, and for those that complete this training and you still have questions, I'm more than willing to answer them through a video, or you can go to our Facebook group. It is the Clinical Documentation Integrity Network on Facebook. You could join there, ask your questions. We have a slew of CDI professionals and aspiring CDI professionals that are there that can help you. I know there are some people who used to and currently work for ACDIS that are there. I don't know if they're going to answer some of your questions, but if you ask them right, they may answer them for you. I may jump in as well, considering that I have other groups to monitor. But if you have questions that you would want me to do a video, I can do that. If there's a topic that you want to go further in depth that goes beyond an hour, I highly suggest you contact your local AAPC chapter and have them reach out to me so that way we can discuss what needs to be created. It may be sepsis, it may be DRGs, which I already have, it may be documentation, inpatient documentation for queries, etc., query types, how to query. I've done all of those presentations. So again, reach out to your local chapter and have them reach out to me. Just suggest them to me, all right? So that concludes this video. I hope this video gives you an idea of what to expect for the exam, at least for this training, not the exam. Hopefully you guys get a good training for 20 hours at $1,800. And for those that are getting it for free, kudos. Make sure you guys look beyond what is being offered in your training. Do your outside research, go outside of the box, because this exam will only get you so far. Again, I think the idea is that this exam will get you to begin a career in CDI, right? The way my take when I was in the committee, I explained to them that this exam and passing this exam should be a stepping stone to the other credentials, including the CDIP, which to me feels like if you're being a director of a CDI program, a manager of a CDI program, and then CCDS is somebody who is really into working as a CDI, okay, and being a CDI professional. So remember that CCDS has a requirement. CDIP, CDEI does not. So to me, it's like a stepping stone into the next credential. All right. So I do want to thank you guys for watching this video. If this video helped you out, please subscribe, please like this video, and also share this video with your colleagues. And so with that being said, again, thank you guys, and I'll see you guys in the next video.
medcodinggeek.com.
Ooh, yeah.